All right, so, like I said, I'm going to housekeep at the end, so we can go over a couple things. Audit sheets are one of them. So, hopefully I'll decrease y'all's stress about that. So, let's get started. We have educated our patient in Preop. We have maintained their safety due to the fact that they've had medication, so we're making sure that they have all their education. We're making sure that they have the side rails up because when they've been given first aid, make sure that they have the informed consent. What is your responsibility for the informed consent? Witness their signature. Are we educating them on the procedure?
No.
That is beyond our scope. Okay? So, we're just witnessing. So we've done all that. We've got the checklist. Their armbands are on there. Their blood bank is on there. And they are ready to go to the intraoperative phase. That starts as soon as we take the patient into the operating room. As the patient comes into the room, it is now a time that we really have to do a last check. Okay? So we've got to do a lot of checks, and we'll talk about that in just a minute, whose responsibility it is and all that kind of stuff. But we're going to do one more check. We've got to make sure that that patient, because they've already had medication, we've got to make sure that they are safe. Okay, so safety is a major, major issue here too. All right, so let me just tell you about the people that's going to be in there. Obviously, our surgeon is going to be in. He is totally responsible for that patient. He is also totally responsible to making sure that that patient is positioned correctly. Now, the nurses do position him or her, but it is his responsibility to make sure that that patient is good and padded like they need to be padded, and we'll talk more about that in just a minute, and that the position is correct, and that they are not going to fall off the table. Okay? That is like, and those of you that's been, or we'll talk about that in just a little bit too, about what all is their responsibility. You may actually see surgical assistants. A lot of times they have PAs or people that they train to assist them during the surgery. So they don't have to say, I need a scalpel. I need this. I need that. They can hold their hand out, and whatever they need is right there. So the surgical assistants, most of the time they're PAs, physician's assistants. You will see that a lot in orthopedic surgeries. But there are lots of times we have surgical assistants in there as well. Anesthesiologists. A lot of times you don't see them a lot. They make the big bucks and they have the big responsibilities, but they're hard to find around there. And basically what it is they are totally responsible for every CRNA. Your certified nurse and registered nurse anesthetist. They are totally responsible for them. So the CRNAs can make their own judgment calls on what medications to administer, but the anesthesiologist is over them. For example, let's say we go in here and the CRNA is giving medication and they're not sure the patient's not responding like they want to. All they have to do is push a button and that anesthesiologist is right there. If they have trouble intubation, push a button, that anesthesiologist is right there. One thing I have noticed at Northeast that I really, really like is the fact that once they start intubating the patient, the anesthesiologist does come in. So they are right there when they're intubating. So as soon as they're intubated, they're out of there. They're just, because they have like 16 rooms to take care of, so they have a lot of people, so they're in and out. But they are over the CRNAs. And our CRNAs, we've talked about them, they're the ones who make the patient go to sleep. They're the ones that have got the weight and height of the patient. They have calculated their medication based on the weight of the patient, and they are able to administer those medications themselves. In other words, they make that decision, whereas we, as nurses, we have to depend on the physician to write the order of what we need to give, right? The CRNA can make that own decision themselves, i.e., if the patient's blood pressure is going down. And we saw that a lot this week. Yeah, either up or down. We saw that a lot the last 2 weeks. And that nurse anesthetist can make that decision on what do I need to do to help that patient's blood pressure come up or go down, whatever it needs to. They have that knowledge. Right. Yeah. And that is, I mean, they are so intelligent and so, they're on it. And one thing that I am so impressed is they remain calm. They are so, I mean, all of them, just so calm. And like when, as a nurse, I look over here and I see a blood pressure of 80 over 40. I'm like, oh my gosh, oh, I gotta go do this, I gotta go do this, I gotta do this. They just grab this, what they need, put it over here, and put it in there. Never get out of shape. But I was talking to one, David, I think it was, who was in there. Sometimes he can be a tiny hole. But for some reason that day, he was really, really nice. Because I walked in the door, I said, okay, you're nice today. Okay, we're being nice. Educated a lot. And he told whoever was in there and said, you know, I have to remain calm. I can freak out after it happens. So they do have, you know, a time where they probably go, oh my gosh, you know, I can't believe I just did that. But that overall they are just very, very calm and do what they need to do for the safety of that patient. Even when Lauren's patient's nose was bleeding out, she was, okay, I got it. We just, you know, do what we need to do, and I'm going, okay, go right ahead. Go right ahead. Yes.
And at the end of the surgery, I got to watch. He metabolized his wake-up meds too fast, and he woke up with the tube still in his throat. He's still in stirrups, strapped up. And the patient panicked. And seeing her stay calm, she leaned over, hugged on his head, calmed him down, and kept doing what she had to do while everybody else was freaking out because he's waking up. They've got to try and get him cleaned up. And watching her just in the zone was incredible.
It's amazing. But I love what you just said. The patient metabolized his medications quicker than they anticipated it. Does that not say that we need to look at every individual patient? Because we can't see what happens in the liver, can we? We can just go on what the patient's signs and symptoms are showing me. Okay, we've got to look at every individual. I'm sure that they did their calculations, but for some reason that patient's metabolism was going like this in surgery, which most of the time it's slowed down a little bit. So I love the way that you picked that up, that patient's, and every patient is different. So I love, this is another thing, I think we talked about this, about the propanol. We'll talk a little more about the medications in just a minute. That's what puts them to sleep, and I love the fact that they just sort of give them a little dose and see how they react. Because why do you want to give the patient the whole drug, the whole dosage, if they don't need it? So this is one of the biggest responsibilities of the CRNA, to give that patient the medication that they need and watch them and react and maintain. The biggest thing is they're maintaining that airway. They are maintaining that airway at all times. All right, and I sort of just gave you an idea or a list of things that they do. They at level of anesthesia, that is they have to watch to make sure that they are keeping that patient in a state of anesthesia so the patient doesn't feel anything, they're not awake, they don't remember anything. That is their responsibility to maintain that level of anesthesia. They are constantly watching the cardiac and pulmonary function. That patient's on a ventilator, so I can see their respirations. The patient is on a monitor, I can see the cardiac function. I can see what their blood pressure is. I can see what their heart rate is. right there. The machine's right there telling us what's going on. The other thing that they watch for is temperature. And I think we talked just a little bit about how they put the temperature probe in their nose, in the patient's nose, so I can have an adequate, you remember, inside the body is a lot better temperature. Obviously, rectal would be the best, but we can't get into his rectum at that point. Okay, so we put the probe in their nose to watch that temperature. Vital sign, intake and output. As soon as they put a Foley in, if they do, they pull that Foley bag right and lay it where that CRNA can see it at all times. She's going to be telling that surgeon, this patient's not putting any output out. Or, I've got output of greater than 30 cc's an hour. They're constantly watching it because that fluid's going in very, very quickly and a lot of fluid. I mean, we're talking sometimes patients get 5,000 liters of fluid during surgery. Okay, so they got to make sure, don't want to overload them. I got to make sure that that eye and nose is good. All right, so let's talk about the different areas of the nurses and this is what when you go to the OR, this is what you're going to be responsible for watching. Holding area, nurse. Your book used holding area. I don't like holding area. I like Preop, but that's okay. I don't have to disagree with the book. Well, but it's a Preop area. So, guys, this is in an acute setting. Okay? When we're talking, the things that you're going to see, the patient has already been to the surgeon, talked about, got their Preop instructions from the surgeon and their nurse. They've already met with the anesthesiologist, so they've already got their education from the anesthesiologist. This is when the patient's coming into the hospital to have their surgery that day. Okay? So their responsibility is to make sure they're ready to go to the OR. The consent form sign. What do you think one of the most important things that they have to monitor? Vitals and what's my favorite thing to do? Airway. What? Lab values. Absolutely, lab values. They have got to keep up with those lab values because if there's anything abnormal, particularly the potassium, okay, particularly the potassium level, I've got to be the one as a pre-op nurse to make sure that that physician knows that these lab values are within normal limits or are they out of whack. And I think Meredith had a patient the other week that had a patient's potassium that was out of whack, and they had to delay it a little bit to make sure that that patient has adequate cardiac function before they go into the OR. A lot of times we have got to reassure the patient and make sure that all of their questions are answered. They feel comfortable in the education that they have been given, that they understand what's getting ready to happen to them. At any time, if you don't feel like that patient has got the adequate questions answered for them, you may have to make that decision on, do I need to call the surgeon? The surgeon will come back in before they go to the OR. They will come back in. So it's really important that you talk to them as soon as they get there to make sure that and sometimes what I do is I get a list. Okay, let's make sure that we understand all your questions need to be answered. If there's something I can't get that I don't know the answer to and the surgeon needs to, I write that question down so as soon as he comes in, because you know just as well as I do, patients freeze when they see a doctor. Don't they? They freeze. We freeze sometimes when we see a doctor. And they can't remember so if I write it down for them, we can say, okay, when the physician comes in or the surgeon comes in, we're going to go through every one of these questions with him to make sure that you feel comfortable with what's going on. So that's a lot of making sure that they have all of their answers, their questions answered. The other thing we've got to maintain privacy. Just sit out there. Maintain privacy for your patient because there are a lot of people going in and out. In the pre-op area, there's little tiny bins that just enough room to get one bed, a little monitor, a computer, and a chair. So we don't want, and their family members are coming back and forth, so we don't want our patients to be seen by everybody else, okay? So make sure that they have maintained privacy and keep those curtains pulled. All right, now, see, that's before we get, the pre-op nurses before we get to the OR, okay? Now we have moved our patient, CRNA gets the patient, takes them to the OR. The first person that they see, the patient sees, is the circulating nurse. The circulating nurse, I just usually say she is, or he, is the ringleader. Because that whole room is her responsibility. She, before the patient ever got there, she made sure that every bit of instruments that were needed were in there. Everything that the surgeon needs or could need is in that room and readily available. Okay, so they want to make sure that everything's in there. The other thing is they've got to make sure that that room, whatever needs to be maintained sterile, is maintained sterility. Okay, so now the other day when Tasha and I put the catheter in, the surgery was over. So I didn't need to maintain sterility all around. I just needed to maintain sterility where we were, in our little area. You're used to having a sterile field about this big. Okay? In the OR, the sterile field is going to be humongous. That whole patient is going to be draped with blue drapes everywhere. So that's why I always tell students, anything blue, don't touch. Okay? Because that is sterile. So they've got to, that nurse has got to make sure that nobody walks by and their jacket gets on the sterile field. I've seen that happen before. Now, I've been taking y'all students to the OR about 10 years. I've only had one student that walked by the sterile field and her jacket hit it. And do you know what happened? Did anybody fuss at her? No, you know what they did?
Just fixed it.
Wrapped everything out, put it over here, got rid of it, got a whole new sterile field and set it up. The most important thing is that we're all human and we all make mistakes. So when we contaminate something, we fix it. We don't just, oh, nobody saw me do that. I'll just get back over here, nobody saw it. We stop everything, we make it right because it's about that patient. And I do not want to jeopardize the safety of that patient and cause them to get infection because I just draped my little jacket by here. Another thing that she is very, very responsible for is prepping the skin. And we talked a little bit about prepping skin yesterday as we got on a big conversation. They are going to prep that skin wherever they need. And we talked, like we were doing a wrist the other day, but they prepped all the way up here. Okay, and we talked about the importance of making sure that the time is covered so it can dry, the prep can dry. It is very, very important. After they prep the skin, you will see them actually put sterile towels over that area. So it's making sure that that area does not get contaminated because the skin is our number one defense against infection. So we've got to make sure. You've got to make sure that that patient's positioned correctly. The other thing that you will see, and I always point out when y'all go to the OR, watch how they position the patient. Because the patient may be in that same position for 3 or 4 hours. So what do you think if they've got a bony prominence somewhere and they're laying in the same position for 3 to 5 hours? What do you think is going to start happening to this skin? We're going to start getting breakdown, aren't we? So what they do is a lot of them just cut egg crates just pieces of it and put it in the areas that they know that the patient, like, this is the way that they lay the majority of the time when they're in OR. So they'll put egg crates underneath here to make sure, because that's one of the worst places right here. And they'll make sure that they're good and padded. There's also this long white thing. If the patient is positioned like this, there is about that thick white pad, and it's, I don't know how long it is, but what they do is they sort of wrap it around the patient. So it's sort of like there's a piece here, and then it goes around the patient, and then it's a piece here. So they actually stick the arm in it so it's padded on both sides and underneath. So it goes all the way around. So padding that patient is major, major important, and making sure that they're strapped in. Because what happened, they actually put a big old belt on them. Because when they get in the OR, the surgeon may need the bed to move. Like, they may need to put the patient in Trendelenburg. And if they put them in, you know what Trendelenburg is, head down. So if they put them in that position, I got to make sure that they're all strapped in, because if I don't, they're going to go sliding out off onto the floor. And I would prefer that my patients didn't slide on the floor. You will also see that circulating nurse working with the CRNA, as when they get the patient all padded, all strapped in, they will start moving the table around. And as they're moving it, they're watching to see if that patient is secure. Are they moving at all when I move this table? So that is a major, major important part of the circulating nurse. They watch the traffic going in and out. Now, I told y'all can go in and out, and there's lots of people that go in and out, but they've got to keep an eye on it, i.e., let's think about orthopedic patients. What's made in the bone? Bone marrow. If that bone marrow is open, what is my patient major at risk for right there? Infection, because that's where. So are you going to see people going in and out in orthopedic? Absolutely not. There's going to be a huge sign up there that says, do not enter hip replacement or knee replacement or something that if I know that it's in the bone, no one's coming in. So once you get in, you're in, and you can't come out unless you're vomiting. Okay?
Then you're supposed to sit down on the floor.
Quickly escort you out the door. Okay? So we've got to make sure that that patient is not put at risk. So we can go in and out, but that circulating nurse has got to make sure that she knows everybody's coming in there. That circulating nurse will also ask you your name, and they will put your name down on the piece of paper. If something happens that we have to go to court, then your name may be called to. Okay, so we make sure. She communicates with the family. One of the things that the circulators ask the patients when they come in is, who do you have with them? As soon as so I need to know, do you have family out there? Because I'm going to be calling them and updating them on what. I mean, how many times have you waited on one of your loved ones in surgery? 15 minutes seems like 4 hours, doesn't it? So it's very, very nice to have that circulating nurse to call out there and say, we've started the surgery. Everything's looking good now. And then an hour later, let's call the family again and tell them everything's going as planned, or we've come into a delay. It's going to be longer than we anticipated. Just so they're giving them an idea of what's going on. You're not telling them, oh my gosh, your patient's bleeding out. They're telling you that it's going to be a little bit longer, because that family member, they're out there, they're really anxious about their loved one being in surgery. So I want to decrease their anxiety as well. So our circulating nurse has got a pretty important job. Scrub nurse and surgical techs. Now, one of the things that we're seeing a lot more of is a decrease in surgical nurses or scrub nurses, and we're going to scrub techs. Why do you think that's happening?
Education track.
Money. Money. Now, what is the difference in a scrub nurse and a scrub tech? Scrub techs cannot assess the patients. Scrub nurses can assess the patient. So you will probably see scrub nurses in very intense surgery as opposed to scrub techs, i.e. cardiac issues, open heart surgeries. You're not going to see scrub techs up there because they need someone that's right in the area to be able to assess the situation that's going on. They don't need somebody they need somebody to hand the tools, but they also need someone that's going to be right there, readily available to be able to assess the situation. The other thing that scrub nurses, and this is one of the biggest things, is when scrub nurses are setting up their sterile table, they have a piece of paper that has every piece of instrument, every gauze, every needle, every syringe, everything that is on that table, there is a list of it. And you will see the circulating nurse and the scrub nurse counting before everything happens. They count every gauze, every needle, everything. And they got to make sure that count is right. So then, after the surgery's over, what do you think they do again? They are counting again. And I can tell you, if that count is off, everybody stops. And we are looking for whatever we're missing. We are looking in the abdominal cavity, just on the floor, we get in the trash, we get everywhere until that whatever we've lost is found. Okay? So that is vital. You know, a long time ago, you heard more of, oh God, did you know that they left a sponge in his abdominal cavity? Now, we saw that was a big problem. You know, that's a pretty big problem, leaving, scalpels and needles and all that kind of stuff in the abdominal cavity. But then we said we got to do something about it. So the count, I'm telling you, you want to see, you don't usually see hysteria in the OR, but if you have lost a piece of equipment, that's hysteria. Everybody's going, oh my God, I gotta find this. It's just crazy. So we don't shut that patient up until every bit of the instruments and everything's been counted for. Did you?
Yeah, this is just Grey's Anatomy, but they actually left a towel in this girl's not longer around for chest and stuff for 5 years.
Yeah.
That really still happens. Like we had, so the hospital I worked at is a main trauma center, so you get something and legally there's only certain things you can put in someone's body, it has to be X-ray detectable. But if you have someone dying, you grab what you can find.
Right.
So in a lot of back or neurosurgeries, if we don't have enough sponges, they'll start rolling up towels that we use to map out the site, and they're not X-ray detectable. And it's the nurse or whoever's scrubbing will try and fight with the doctor, you're not putting that in the patient, and taking it back. Well, we had someone.
Good.
It was I guess last summer, they had surgery and went back multiple times because they just kept having pain and stuff in their lower back, and the back surgeon was like, well, I fixed what I could fix. So,
Right.
So he went to someone else for another consult. So he was like, well, have you done an X-ray for your surgery? Well, no. So they did an X-ray, and they couldn't see what it was, but there was something in there, and there was causing an infection. So they took him to the other surgeon at the same hospital, and as soon as we put him open, there was a towel that the doctor had put in previously, and one of my best friends is his scrub, and she was like, I told him that day, you put a blue towel in there, you cannot put it in there, I know you put it in there, and it's we have to argue with them, but if they're already closing, they're like, well, no, it's not. I mean, you can only, the nurse documented, that she thought he put it in there, and I mean, there was a big lawsuit, because
absolutely.
because he had a towel in him for 6 or 9 months, just rolled up, infected, and that.
We've got to be more assertive and say, but you're right, in an emergency situation, but I'm sorry, you need to make sure that you have everything that is there before you close that patient up. And yeah,
Like our hospital switched to, actually a lot of them now, where we had blue towels to map out under the drape. Now you can put those down, but once the drapes are on, there can't be any blue towels out anywhere. We have all green X-ray detectable, like even on your table, under your instruments, like if it can be seen, it has to be green.
good, good.
Yeah.
So we see that there's a problem, so we're doing things to fix it.
There was 2 different scrub techs in the surgery I was in, and one of the surgeons needed a longer retractor than what his tech had. 3 different forms had to get signed for them to move it from one table to the other.
Good.
And watching that, and they recounted like 2 times mid-surgery just to make sure that retractor processed.
Absolutely. I'm loving this. Because it's all, I don't want to keep things in patients.
I see that 4 times.
4 times?
4 times.
Yeah.
Anytime you're closing, you have to do an opening count, and then anytime you close the cavity. So before they sew the uterus, they have to close. And then before they close the skin, they have to close, and then you go final count.
Absolutely. So I'm just
Yeah,
loving
so it's
this.
the first count, closing the uterus, closing the skin, and then when it's all done, after, like there's 2 closing counts, plus the extra. Because like if you do, like say you do a bowel resection or something, before you finish closing the bowel, you have to count and make sure you count something in that.
Yeah,
And then you do another one.
Even though our non-X-ray technical everything. And we had somebody get a sponge left in. The circulating nurse was responsible for the scrub tech and the doctor.
So you can see this is pretty important stuff. So that, you know, you're like, oh my God, why in the heck are they counting? Well, there's a reason why we're counting. And it's pretty, and we're seeing that patients are suffering if that count is off. This is a major, major responsibility of the scrub nurse. The other thing, and I'm not wanting to stop your stories, but I do need to get through all this. The other thing that you'll see is specialty nurses. Those are ones that have went with surgeons, got more education on field. They only want to do cardiac, or they only want to do orthopedic. One of the major resources that I use down at Northeast is Jody. She is specialized in orthopedics. She knows everything about orthopedics, so I always use her and have her, or if I can, we have time, to let her talk to you about the importance of what happens in the OR. So you can specialize, and you can only do orthopedic if that's what you like, or you can only do cardiac if that's what you like. Okay, so it's really a wide variety there. All right, so we're looking at the prepping of the surgical suite. The suite has to maintain a certain temperature. We talked about this the other day. Because we know that bacteria likes hot. So we keep it cold, 68 to 73 degrees. Electrical safety is major important, and I think Samantha shared a lot about the different things that can catch on fire in there. So we've got to make sure that the patient is not at risk for getting electrocuted and starting a fire. So fire prevention is major. We have grounding pads that you will see them put on the patient, and a lot of times the circulating nurse will say, are they grounded? And it's just a big old pad, and they generally put it on the thigh. So you will see them just place that pad on them to make sure that they're grounded so they don't get electrocuted. Okay, there's 3 different areas that are zones. And if you've ever noticed that the surgery area in a hospital is sort of off to the side, where there's not a lot of traffic going in. I mean, if you've ever been on a med-surg floor, how much traffic's going around there? In the OR, I don't want any traffic there. I don't want anybody that's not supposed to be in there. So there's different areas that we've got to make sure that we have the proper attire on when we go into these areas. So there's an unrestricted means that it's sort of the outside. Like down at Northeast, it's like a box. That's how I explain it to everybody. This is like a box. So there around that box is an unrestricted. So there are people that can walk around there and not need extra equipment on their bodies. The semi-restricted is right in the area where inside the box, but not inside the surgical suites. So around that, but you still have to have your cap on. You still have to have your shoe covers on in a semi-restricted area. Okay, so you've got to have that covered. There is a lot of evidence-based practice going around now, and they are getting ready to make a lot of changes about how the semi-restricted area and restricted area is. I.e., one of the things that they're saying, you know how we love our little lanyards and our little bling bling on our name badges? Well, they're getting ready to go get away from that. They're getting ready to be just one singular little clamp that you have on your name. Because if you think about it, even with y'all, you've been taking care of med-surg patients. Does any of you ever clean your tag? We got one. Huh? You clean. Yeah. So that is something that, I mean, did you really think about that? I didn't think about that. As a student, I would not have thought about cleaning my badge. But you've got all that stuff on there, and you've been in and out of patients who've had MRSA, and this, that, and the other, and I don't want that in the OR. Okay? So they're going to get away with all the bling bling going in there, and just having one little clip to have your, I can't wear my lanyard after March to something. So I'll have to give me another little clip to go in there because they are seeing that could possibly have caused some infection issues. So in the semi-restricted, there are a lot of things coming out. Another thing is that they want everybody to wear long sleeves. So any of my skin, you know how hot-natured I am. That's going to be really hard for me, but I got to do it for my patients. I'll have to sweat just for them. But no short sleeves. They're going to be all the way long sleeves because that's covering a lot of our skin that might not be clean and taking it into the OR. So there's lots of evidence that are proving that we've got to do some things that my patients are still getting infected. So I got to change some things that are happening in the OR. Another thing in the restricted area, when the restricted area means that you're going into the actual OR suite. When you go in there, you have to have your head, feet, and mask on. Okay, you have to have that mask up and going when you go in there. Every time you go into the room, you foam in, and every time you come out, you foam out. We've got to decrease the patient's risk of infection. So there's different attire that you have to wear with each one, but we've got to make sure that we're decreasing this patient's risk. Oh, backwards. That's what I just said about there's different policies and procedures of each facility that address. Another thing that they're talking about is not letting you wear any of your personal clothes underneath your scrubs before you go in the OR. That's been a big controversy because we've got lots of people that are cold and they want their long sleeve shirt, but we've got to remember that we can just keep on putting blankets or putting on jackets if we get cold. So they're trying to decrease patients or nurses and us from wearing our own attire in there. Like I used to tell you, oh, if you're cold natured, go ahead and wear a long sleeve white shirt underneath that, and then we'll put the scrubs on. They're trying to get away from that right now.
Couldn't the hospital just maybe start providing one?
That's what they're doing with the jackets.
Oh, okay.
They are making the jackets. Everybody wear the jackets. That's why I say to you also is if you have a temperature, you can't go. We have anybody that has any type of process in their own body, like a fever, an open wound, or anything like that, you can't go to the OR because that's putting that patient at risk for infection. Good personal hygiene. Make sure you shower before you go to the OR. Jewelry. And if you see anything, if you start having anything on your hands or any open wounds, they will take specimens of it to treat you before and say, are you okay to go to the OR with whatever you got going on? Okay?
So if they have, like, they're on anything with contact or droplet, they cannot be in the operating room.
The patients
Right.
can.
So they can.
Yes.
Is there special?
Now, I don't like to take anybody in isolation to the OR, but there are times that I've got to take them in the life situation. But yes, I'm talking staff here. My patients, yeah. If I have a patient who has MRSA, then that room is cleaned at a different protocol than what it is if just a patient who comes in and doesn't have any. But most of the time, like if a patient has pneumonia, I'm not going to take them to the OR anyway because they're sick. If they have fever, I'm not taking them to the OR. They don't need to be there. All right. We've talked about what you need to do as far as what you need to wear when you get to those of you that are going to be coming to the OR. You have to put a new set of scrubs on every time you come in. Okay, so you put your scrub pants, your scrub top, you get a head cover, you get shoe covers. I have hats for you so you don't have to wear the little bouffant. You got a special little hood for you. You want a bouffant? You can have a bouffant. I don't care. The other thing is, I usually encourage you when you go into the room to go ahead and if you're going to touch the patient, go ahead and put some gloves on. You cannot touch these patients in here without having some gloves on. Okay? Because you never know when something might fall out, stool, urine, something. You gotta be ready to help that patient. So go ahead and put you some gloves on. The other thing, if you're going to be right there in the middle of everything, like if they're operating in the abdominal cavity and you're right here at the head, get something to cover your eyes. Okay? Because you will get splattered. And if I forget to get you eye covers, the staff will get them for you. The fact they will say, you're not getting that close without having something to protect. So they'll look out after you.
Jody made me, whether I was in the corner or right up against the feet of the bed.
But you were in orthopedic, right?
Right, yeah.
Orthopedic, we got a lot of drills going on. We got a lot of hammers. That's blood splurting everywhere. That's bone going everywhere. So you got to remember, we got to protect yourself. So if anytime, get you some goggles. I covered all that. Oh, this is a surgical scrub. I do not have surgical scrub. All right. Now, woo! All right. Well, this is not really scrub. Yes.
It says above
I got to figure out where I'm at.
It says above it. Surgical scrubs does not.
Oh, I can't see it on mine. What's it say?
Arms sterile.
Oh, I can't see it. I was like, I thought I had that on there. All right, so at least y'all can see it. All right, scrubbing before we go in. That is with you, since you're not operating. At least I hope you're not operating. The foaming in and foaming out is okay. But when you see the nurses that are scrub nurses, or the surgeons, or whoever's going to be right there in the midst of everything, they have to do a special scrub. Outside of every OR suite, there are huge sinks, just like Grey's Anatomy. Just like that, there are huge sinks. And you will see that they have scrub brushes, and that they will have the little orange sticks. Do you know what I mean by the orange sticks? You will see them taking that brush and going up and down and vigorously all the way up to the elbows. Okay, it's not just a let me sing my ABCs. This is major scrub. They get underneath the fingernails. You'll see them going like this. I mean, they take all jewelry off. They are scrubbing like crazy. And then after they do, most of the time when y'all wash your hands, you do like this and let everything go off here. The water, not for a surgical scrub. Oh, let me just say, you've got to wash for 3 to 5 minutes. Now, there are some different things that are being tested now for scrubs. Different types of, I guess it's scrubs, that they're using to not take as long a time. You know what I'm talking about?
Yeah, it's different concentrations of it. Like, they have iodine scrub and then and if you use iodine, it's more of the actual vigorous, like 3 to 5 minutes. And if you use chlorhexidine, technically it's that like counting like 30, 30, 30, 30.
So scrubbing and a count.
Yeah.
Right. So I'm not really familiar with all the different changes
But, like,
that they made down here.
It has a timer on it, so when you kick the water on, a timer will start, and you're supposed to stay there scrubbing the whole 3 minutes. Because we only scrub initially in the morning before you go to your first room, and then if you're like really dirty, because even if you're down the blood, you'll still get blood on your
Right.
arms. So if you get like sore like that, then you scrub. I was like, obviously, but if not, there's a scrub that's like hand sanitizer. So if you're in like a quick case or something, and you break scrub, flip the room, and you go to your next one, you just
Use that.
sanitize it instead of scrubbing all day.
So you're going to see a lot of people. At this point in your observation, you do not have to scrub in. Okay, so you don't have to do the different scrubs. But when I was talking about the water, we used to let it run like this. They let their arms and go like this underneath the water. So the water comes out like this. And you will see them after they have scrubbed the appropriate amount of time, clean their nails like they need to. And I love the fact I've never seen the timer. I don't know if Northeast has a timer, but I think that's pretty awesome. Because, sometimes we think, oh, how long have I been here? Well, this is a time that I really, truly got to do the whole 3 to 5 minutes. Okay? And there's a reason why, because of the bacteria issue. So when they actually run their hands through the water, they'll pull their hands up like this, and then and you'll see the surgeons walk into the OR like this. Okay? So as they walk in, after they have done their scrub for the appropriate time, the circulating nurse will then bring them some sterile towels. So they've cleaned their hands like they need to, and we're using sterile towels to dry them. And at that point, the circulating nurse will help them put their gown on and their gloves. So I want you to watch when you're in the OR, watch the circulating nurse or whoever's helping the surgeon get into their attire. A lot of times that surgeon will walk up to you because they know that you're a student and say, tie me up. Okay? And you're all going to go, there is a, right. They whirl. So don't freak out, because what they're going to do is they're going to walk up to you, and the tie that goes around their gown has a piece of paper on it. Okay? And all you got to do is stand there and hold that piece of paper, and they'll whirl. Okay? And when they whirl, that you're still holding it. You hang on to it as tight as you can. Okay? Because when they go around, it's going to break off, and they're going to grab it, and they're going to tie themselves. Because they already have sterile gloves on. They already have it. And what they're needing to do is make sure, just don't get close to them. Just stand away from them like this and hold on it for your life and let them whirl. Okay? And they will have you do that when you're in there. So I want you to look at, and as we've talked about things that go on in the OR, is can you hear this constant thing about infection? So when you're in the OR setting, that's what I want you to look. I want you to be able to put it together that the reason why they're scrubbing 3 to 5 minutes is to decrease that patient's chance of an infection. I want to know that as they're maintaining sterility, you're understanding that it's all about that patient and making sure that they're sterile. Okay? Arms their elbows, they're assisting, yeah, they're sterile, casing. All right, now, Samantha said something about nurses not having to scrub, if they break the scrub, having to come back in. Now, our surgeons, they are going to scrub after every case, or before every case, okay? They're ones that have to go through that major ordeal every time before they go in, okay? All right, I've made it that far. Y'all ready for a break?